now excited to introduce Dr. Joanna Mack, who is a pediatric hematologist oncologist who's the director of the Vascular Anomalies Center at Arkansas Children's. She did her med school at Ross University and residency and fellowship at University of Arkansas. She leads several research studies in the treatment of patients with vascular anomalies. And I learned last night at dinner that she does all this while having 5 children at home, which is just colored me very impressed. But we're really excited to have her here and presenting her talk on vascular malformations. Sure. Yeah.
Is that okay?
Yes, absolutely.
Okay. Well, thank you guys all for being here. I'd like to say thank you to Dr. Meehan first for inviting me to give this talk, and to the organizing committee, which I don't know all of your faces, but I know it takes a lot to do a symposium like this, and to everybody else who's here on a Saturday. Your weather is better here in Austin than it is in Little Rock, and it's much prettier. I guess that's why you moved. As some of you may know, but I've known Dr. Meehan for over a decade now. He's the one who really pushed me to go into the hem-onc field. My first publication was with him, and so I just want to thank you for your mentoring and your guidance throughout the years. And so now I get to talk about vascular anomalies. I have no disclosures, and where did that... And we will be discussing off-label use of medications for vascular anomalies. We'll discuss briefly the International Society for the Study of Vascular Anomalies classification for vascular anomalies, and then we'll discuss the current targeted therapies that we're using. We'll go through guidelines of dosing and monitoring for vascular anomalies, and then finally we'll end with future therapies. The next few slides are cases, just so we can be a little bit interactive. And if you know nothing about vascular anomalies, it's okay, just guess, okay? So this is a 2-month-old baby girl, for the most part healthy. At about a week of age, she had right eye swelling, and this is a really cool pointer. Right eye swelling that ended up developing into a little nodule. And while that nodule was developing, she had other lesions pop up. The nape of her neck, it's kind of purplish red, slightly raised on her cheek. I don't know, does this make people dizzy? Sorry. The abdomen, and then just in the right upper shoulder. So again, she's been healthy except for these lesions. She was referred to me to start propranolol for what we are calling hemangiomas. So my question to the audience is, would you start propranolol based on these pictures? Would you want more imaging? More something. A biopsy, maybe. We'll start with imaging. So when I saw this patient in clinic, it just didn't have that hypervascular look that I'm used to with the hemangioma. And I know there's a lot of PCPs out there, and you guys are probably the first people to see these hemangiomas. This eyelid nodule does not necessarily resemble that. And so I got imaging of some of the nodules and some of the other lesions, and the radiologist read it as arterial and venous blood flow consistent with a hemangioma. Because she had 5 lesions, not all of them were over 2 centimeters, we usually get a liver ultrasound to make sure there's no liver hemangioma. Well, I didn't find a liver hemangioma, but I found something else. I found a huge renal mass. After that, we did further imaging. We found several lung masses, a pelvic mass, and I'll tell you, I didn't find any of this on physical exam. We went back and checked to make sure, and we did not feel any of this on physical exam. So after a little back and forth with surgery and IR, we finally convinced them to get a biopsy. We got a biopsy of the lesion on the neck, and then also a lung biopsy, just to make sure they were the same disease process. And she ended up being diagnosed with multifocal, multisystem, ALK-positive histiocytosis, a rare subtype of juvenile xanthogranuloma, thanks to people at Cincinnati who helped us with the diagnosis. Obviously, nobody was thinking that. This baby had this nodule for a month and a half before she came to see me. She was started on vinblastine and steroids, and 3 months later, most of the nodules, or the skin lesions are gone, and most of the masses are completely gone, and she's doing very well. Okay? All right, next case. Hemangioma or not? So this is a 3-week-old baby. He may be a little bit older because the hand looks a little bit bigger than a 3-week-old. But let's just 3-week-old baby who full-term newborn, healthy otherwise except for this huge something on his hand. At about 7 days of age, had a little pimple-looking thing on the left thenar eminence. This pimple started to grow pretty quickly and started to encompass the left thumb. It started to go towards the wrist, as you can see in this picture, and was recommended to the vascular team, not my vascular team, but another vascular team, for propranolol for a hemangioma. Anybody would start propranolol on this patient? I've always heard the saying, no meat, no treat, or something like that, right? We need to get a biopsy to make sure that these sorry. So it was very hard to get a biopsy because this lesion was very hypervascular on an MRI. Nobody wanted to go into this tissue because they thought it would be very risky. And the MRI sure did show arterial blood flow, venous blood flow, consistent with a hemangioma. That doesn't look like a hemangioma to me, and it actually looks like a very scary malignancy. And so they came to an agreement. They started propranolol for a month. Can anybody guess what happened after a month? Did it shrink? It didn't. It grew even larger. It did have some ulceration, but they think it was because the patient rubbed it on something. They finally agreed to a biopsy because it was much larger than this, and it was rhabdomyosarcoma. I don't know how this child is doing now, but the last that they were talking about was, they ended up starting some treatment chemotherapy, and even after the chemotherapy continued to grow, and they were talking about amputation the last I heard. Okay, Klippel-Trenaunay syndrome. Which one of these is Klippel-Trenaunay syndrome? Klippel-Trenaunay is a vascular malformation with overgrowth. There's a couple most of them, if you look at the pictures, they look like they have overgrowth. So we'll start with, where'd this go? Oh, I broke it. Okay, 1, 2, 3, or 4. Anybody votes for 1? Again, if you don't know what Klippel-Trenaunay is, it's okay. You could do 2, 3. I see more 3s. And then 4. Okay, we're gonna start with 1. So this is a young lady, she's about 7 years old. Obviously you can tell her right leg is probably 3 or 4 times larger than her left leg. She does have some capillary malformation that you can see that discoloration. On MRI, she has an AVM in her spine, and she also has a germline mutation of RASA1. Her mom and everybody on her mom's side have these little telangiectasias, and it's hereditary. And so this patient has Parkes-Weber, or we also call CM AVM with RASA1 mutation. So that one's not KTS. The next one, number 2, it's a 25-year-old male that we have treated at our institution for years, calling him KTS, even starting him on sirolimus, which you'll hear about in my talk in a little bit. Sirolimus did not do him well. It didn't do anything. It actually prevented wound healing, and he had a lot of infections. And so, but he has overgrowth, and he just really looks like somebody that has KTS. We finally got a biopsy recently, which revealed a RAS mutation. So his genotype is more similar to that first one of this RASopathy CM-AVM. The third one is actually, most of you guys, or some of you guys got it right, is KTS. You see the capillary malformation, there's some lymphatic blebbing and overgrowth. It's hard to see overgrowth, but trust me, she has overgrowth of that left leg. She has a PIK3CA mutation, which we'll talk about in a little bit, and she has Klippel-Trenaunay syndrome. The last one is not KTS. For the pediatricians out there in the community, when you see these newborn babies, this is considered a medical emergency. What if I told you that she does have this violaceous area, violaceous area of a lesion right there on her thigh, but the lesion goes all the way up, subcutaneously all the way up to her hip, and it goes around her thigh, and she has a petechial rash. Anybody else can guess what this may be? Kaposiform hemangioendothelioma with Kasabach-Merritt phenomenon. KHE with KMP, yes. And this patient actually did really well. I wish I had another picture to show you. She was started on sirolimus and steroids because of the Kasabach-Merritt phenomenon. That's why I did the steroids. And now she is walking in her legs. You wouldn't even know that she had this lesion. But it is a medical emergency and needs to be sent away to a bigger center immediately. Okay. Now I have to go back here because I need to read some of my notes. Okay, so this is the ISFA classification. You can find this online. They delineate vascular tumors, which are your hemangiomas, that again, a lot of our general pediatricians will see out there first, the congenital, the infantile hemangiomas, and KHE. And then on the other side, we have the vascular malformations, the simple malformations, the ones that are combined and the ones that are associated with overgrowth syndromes, just like KTS. And so, as you can tell with all those cases that I showed you, one of the biggest challenges we have in the field of vascular anomalies is getting the diagnosis right. And hematologists and oncologists, we have an important role in taking care of these patients because they can have so many complications, from bleeding to thrombotic complications to, and really, we're, as an expert, we need to provide that expert use in targeted therapies adopted from other areas of oncology. So we have moved into the era in vascular anomalies from molecular into the era of molecular diagnostics for these disorders. We've moved from naming them with eponyms and other clinical feature descriptions to describing vascular lesions based on the vessel or vessels of origin, and now with the addition of subcategorization of their molecular driver. So from phenotype to genotype, Klippel-Trenaunay syndrome to capillary venous plus or lymphatic malformation with overgrowth, and now PIK3CA-related overgrowth spectrum. And truly, this has allowed the role of the hematologist-oncologist to shift from supportive care and complication management, like with NSAIDs, gabapentin, pain management, or antithrombotic therapy for other pain management like aspirin and DOACs, to the use of precision medicine using targeted therapies aimed at inhibiting gain-of-function genetic drivers of these conditions. For example, mTOR inhibitors like sirolimus, PI3K inhibitors, MEK inhibitors, AKT inhibitors, and anti-angiogenic agents. So as our knowledge of these molecular drivers has expanded, so too has our ability to use medical therapies to control symptoms and disease. And we are now beginning to be able to map out both of our knowledge of the molecular drivers of vascular malformations and their associated therapeutic targets. So on the left, you can see that RAS MAPK pathway and all of the diseases that we have seen genetic mutations in, and the targeted therapy that we have for those specific genetic mutations. On the right, same thing, the PI3K, AKT, mTOR pathway, and the diseases that we have and the medicines that we can use for these genetic mutations. And truly, to tell the story of how sirolimus, how we started precision medicine or targeted therapy in vascular anomalies, I have to tell the story of sirolimus. This is a story, really, that's Dr. Denise Adams, who, while she was at Cincinnati Children's, was caring for a child with Kaposiform hemangioendothelioma. That was that fourth picture that I showed you in that slide. It's a rare and aggressive vascular tumor, and it did not respond to any standard or previously accepted therapeutic agents like vincristine or Cytoxan. And based on some of the work that was done in the vascular biology lab at Cincinnati and the known efficacy of mTOR inhibition in vascular tumors, especially seen in like tuberous sclerosis complex, sirolimus was trialed in this patient and ultimately was extraordinarily successful. So this one dramatic case spurred a series of additional case reports and case series about the efficacy of sirolimus in controlling vascular anomalies. And this is, you could see that the most recent picture, which is probably a couple years old too, her leg discrepancy is, you can barely tell. She does have some hyperpigmentation of that leg, but just as like in my patient, she's walking, she's doing well, and she survived that KHE and the KMP initially. So after that initial patient, this spurred the first prospective clinical trial of sirolimus that included more than 60 children with complex vascular anomalies. And with over 80% of the patients having partial response or stable disease, this trial ushered in a new era of precision medicine for these disorders. I remember this paper coming out in pediatrics. I was a first-year fellow, and it really cemented my desire to go into this field because of what the potential was going to be to treat these patients. Okay, so here we see just one example from a patient in this trial with an extensive mixed macrocystic and microcystic cervical lymphatic malformation, who showed dramatic improvement both clinically and radiologically to sirolimus. And so since that time, thousands of patients have been treated with sirolimus, and its efficacy has been confirmed in other studies nationally and internationally, making it a really critical part to comprehensive care for children and adults with vascular malformations and tumors. It's just amazing that sirolimus did this for this patient who would have likely had several surgeries, probably would never have been able to be decannulized from his trach, and he's still cannulized in this post-study picture, but I'm sure at this point he's probably decannulized and hopefully living a normal life. We have several patients at Arkansas Children's that we treat like this. So we use sirolimus across a wide spectrum of vascular anomalies, including venous and lymphatic malformations, vascular tumors like the KHE, and then also complex lymphatic anomalies. While dosing is based primarily on pharmacokinetic information from that initial trial with Dr. Adams, many clinicians have been moving towards lowest dose possible to still achieve the effect. Meaning we don't want to necessarily stay at 0.8 milligrams meter squared BID for children. We want to get them on the lowest dose to see if we can still help them decrease their infections or decrease swelling or decrease pain. And some institutions in Europe are even doing intermittent dosing, only using sirolimus right before they get a surgery, right after they get a surgery, or right before they hit puberty. We have a topical formulation. I don't know, Gina, do you guys use topical sirolimus very much here with capillaries? Okay. So there's a topical solution formulation of this for sirolimus. You get it through special compounding. It's getting harder and harder to get approved, but it's very effective in cutaneous lesions with patients with capillary malformations, especially around their face, and it doesn't lead to any kind of systemic absorption. But for those of us who do use sirolimus orally, we know that there can be adverse effects, and it's well documented, especially in the use in organ transplant. And so some of the side effects is mucositis. That's what I most commonly see, immunosuppression, hypertriglyceridemia, and then at its severe effects, pneumonitis. But for the most part, it's very well tolerated, especially because we have lower dosing and lower troughs than solid organ transplant patients. And really, despite the immunosuppression effects, there hasn't been a lot of serious infections in patients on long-term therapy using sirolimus. Recently, there's been some concerns raised about sirolimus and the effect on fertility, which you're going to have a fertility talk in a little bit with Dr. Burns. And so it prompted our Vascular group, this European network of institutions that treat vascular disorders, to come out with a consensus statement stating that the current evidence, especially in the solid organ transplant world, that fertility is minimally affected with sirolimus and reversible. And so obviously informed decision-making with your patient is always important to let them know that this could be a potential, but I've had several patients have children after using sirolimus. One of the other debates that we have is using sirolimus or using Bactrim due to the immunosuppression for PJP prophylaxis. I use it throughout the whole treatment while they're on sirolimus, but some people will just use it if they're less than 2 years old, if they're on steroids concurrently, or if they have evidence of lymphopenia or any other immune disorders. Okay. Since those first case reports in the 2000s, and definitely since the 2016 trial, sirolimus has been a mainstay of our medical therapy for vascular anomalies. But there's always been a subset of patients who have not responded or had less than adequate response. And this in particular includes our patients with overgrowth, extensive venous malformations, and those limited or have had a plateau in response to sirolimus, or those who have unacceptable side effects like mucositis and immunosuppression. I remember as a fellow telling Dr. Christian Richter, he's an ENT, he's our surgical director of our vascular anomalies group, that I didn't know anything about vascular anomalies, but I wanted to help treat these patients. And he said, you know, it's worse than cancer. And I said, I don't think it's worse than cancer. And he said, well, a lot of your cancers have protocols, COG protocols, have good prognosis, and these patients don't have anything. And at that point, we only had sirolimus and then pain medicine. Nobody was using anticoagulation yet. So at that point, it was just sirolimus, and he said, we don't have anything to really treat the underlying disease. And this is where the talk gets interesting. So this is where the alpelisib story begins. Because there were a subset of patients with severe vascular malformations that would not respond to sirolimus. Alpelisib is an oral PI3K alpha inhibitor, and it targets the first step in that PI3K AKT-mTOR pathway that increases vascular growth. This compound was developed by Novartis as a cancer therapeutic. You guys may have heard of it. It's been approved for the treatment of breast cancer. It's called Piqray, approved in 2019. And the first reported use in vascular malformations happened to be by a nephrologist. And he he published his data in 2018. And I also remember this as I was ending fellowship. We were at an ASFO conference, and all these vascular anomalous peds hemonc doctors were itching to get their hands on this medicine because Novartis wouldn't give it to us initially at that time. But this French nephrologist, Guillerme Canot, Dr. Canot had a patient with Clove syndrome, which is one of those severe vascular malformations with overgrowth, and he was dying from spinal cord compression due to this lipomatous overgrowth. And then it was recognized that he had a PIK3CA mutation, and the drug was given to this patient under compassionate use and ended up dramatically shrinking this mass and saving his life. And so then Dr. Canot and his partners used this drug in a cohort of 19 patients in France with severe overgrowth and PIK3CA-driven vascular anomalies, and published, like I said, published the results in 2018. And here demonstrated this excellent response in one of these patients who had extensive overgrowth with combined lymphatic and venous malformation in the right upper chest and arm. And you can see after 6 months, the lesion is smaller, and the child has also become much less malnourished on drug therapy. And so following all these early reports in France, Novartis ran a phase 1 and 2 trial that also offered a managed access program for patients with severe disease. The primary response was measured by reduction in target lesion volume by at least 20%. While only a third of the patients, about 37 of them, responded or met this endpoint, many more reported clinically significant volume reduction at a mean of about 13%. And they all had, or the majority of them had marked improvements in pain, fatigue, limb asymmetry, and coagulopathy. Many of us in the vascular anomalies world took advantage of this compassionate use program to obtain therapy for our most severe patients who previously had no alternatives. And this photo collage on the top demonstrates a patient and the remarkable response to alpelisib to control their PIK3CA-driven facial overgrowth. It is just amazing to see from diagnosis to 2 years being on this medicine how much that has decreased in size and has probably improved his quality of life as well. Below in the slide is another patient with extensive microcystic lymphatic malformation. You can see some of those bubbles in the tongue. It's kind of bluish discolored. It causes a lot of pain, especially when they're swelling. They can have infections. They can also have little phleboliths in those little clots in their tongue, which causes a lot of pain. And so he has the lymphatic malformation in his tongue and in his oral cavity, and you can see being on alpelisib after 6 months. It's a little hard to see in that second picture of his mouth, but has definitely significantly decreased, and you can see it on that the image there that it's decreased as well. So in 2021, the EPIC-P2 study began enrolling patients in a prospective double-blind randomized control trial to assess the efficacy and safety of alpelisib in patients with PIK3CA-related vascular anomalies. And today, there's more than 160 patients enrolled down to age of 2 years. And although this trial is still ongoing, the early phase 1 and 2 data led to FDA approval in 2022. Now, I also remember this. One day, I'm gonna say back in the day, but right now, I'm living this era of treatment for vascular anomalies and the improvement of it. In 2022, in April, I think it was about a day or two right before the ASFO conference that we got FDA approval, and obviously we were excited about this approval for our patients. So in the vascular anomalies world, we now use this drug regularly in overgrowth, the extensive venous malformations, and in complex lymphatic anomalies. Current dosing is typically 50 to 250 milligrams per day. Those smaller doses have been used off-label in younger infants. I haven't used it in anybody less than 2 years of age as of right now. We also await additional information from the EPIC-P2 study to provide guidance on dosing and monitoring through pharmacokinetics. And although not immunosuppressive like sirolimus, alpelisib has its own toxicity concerns, including risk of hyperglycemia, which requires close monitoring, and then long-term toxicities remain truly a big unknown, especially in growing children, where they may have concerns about suppression of normal somatic growth. So who is our patient? Who would we treat sirolimus with, and who would we treat alpelisib with? So when helping a family decide about initiating targeted medical therapy, we take all of these factors into account, knowing which drugs might be more helpful for specific vascular malformation subtypes, weighing the side effects for each individual patient, and of course taking into account growing but still limited long-term data. In contrast to oncologic treatment, many vascular malformation patients require long-term or even lifelong therapy. So carefully weighing the risks and benefits and coming to an individual treatment goal and consensus is critical for these patients. Okay, so next I want to touch on a drug class that has changed the course of management of complex lymphatic anomalies significantly, and those are the MEK inhibitors. This quite recent discovery of RAS pathway variants are as drivers of complex lymphatic anomalies, including, here's another long disease, Kaposiform lymphangiomatosis, or KLA, and Gorham-Stout disease, as well as many extracranial AVMs. This led vascular anomalists in the past several years to trial these agents for these super rare disorders. So until very recently, liquid formulation and use of trametinib in pediatric patients was only available as a single-use IND. But the drug received FDA approval for a pediatric brain tumor indication, so that expanded our ability to use it. A few prospective trials exist evaluating these agents in extracranial AVMs, but current use in complex lymphatic anomalies remains highly individualized, and like with patients with central conducting lymphatic anomalies. So really, even though these agents have been life-saving for some, there's a lot of associated multiple toxicities: GI, skin, ocular issues, pancreatitis, and cardiac toxicity. So MEK inhibition has been highly successful in Kaposiform lymphangiomatosis, KLA, which is a complex diffuse lymphatic anomaly with bony involvement, includes pleural and pericardial effusions, and often they're coagulopathic and have hemorrhage. And historically, KLA has had a very high mortality, and traditional therapies have included vincristine, steroids, sirolimus. But the recent identification of RAS pathway variants in KLA has really spurred the use of MEK inhibitors in this patient population and has been very successful. And so here are images from a report by the lymphatics group at CHOP that first showed the successful management of significant pulmonary lymphatic disease in a patient with KLA, including evidence of new lymphatic growth and remodeling while on the drug. So it's pretty significant how much this patient responded to a MEK inhibitor. Gina, I don't know, do you guys have any KLA patients in this region? I've been in practice about 7 years now, and I've only had one KLA patient, so they're very rare. Most of them will go to CHOP, maybe Cincinnati. So we've talked now about how we treat different types of vascular anomalies, but both venous and lymphatic, as well as tumors and overgrowth syndromes. But targeted medical therapies effective for our fast flow lesions, like arteriovenous malformations, remain an area of significant need. We've learned that loss of function variants, TGF-beta signaling pathway, are involved in germline predisposition to AVMs, such as that seen in hereditary hemorrhagic telangiectasia, or HHT. But many sporadic extracranial AVMs are due to gain of function variants in RAS or MAP2K pathway. So this is a patient of mine who has a significant AVM of her face and her oral cavity, and every couple of weeks she comes into the ER because she's bleeding from her AVM. More than once has she been in the ICU because we could not stop the bleeding. And we've tried very hard to find treatment for her. Sirolimus didn't work, of course it didn't. We've tried to get trametinib for her, but insurance hasn't been able to pay for that. And so we are looking for other drugs for her to help her have a better quality of life. We have I lead a study right now at Arkansas Children's looking at cobimetinib, which is another MEK inhibitor, in patients with extracranial AVMs. They are on the medicine for 12 courses, so about a year. And we've been slow to enroll, but the few patients that we have on cobimetinib for AVMs, with the primary endpoint of decreasing their target volume, they've all had decrease in their target volume. And the side effects are pretty minimal. The biggest one is acne. It's hard for my teenage patients. And the other one is fatigue, but pretty well tolerated. In the HHT world, so that's the hereditary hemorrhagic telangiectasias, there are several anti-angiogenic agents that demonstrated efficacy in reducing bleeding and transfusion requirements. This includes bevacizumab and thalidomide and its derivatives, both of which have shown promise in prospective trials. Pazopanib is currently under investigation as an anti-angiogenic TKI that may decrease bleeding-related transfusion requirements in HHT, and several other molecules are in the pipeline. And so, however, these agents seem to be best at decreasing those small little telangiectasias that you see, or the micro AVMs, but their efficacy in treating already established macro AVMs, those larger AVMs, is really unclear. So the information that we've gained from treating HHT as well as other vascular malformations that harbor RAS pathway variants has spurred clinicians to utilize thalidomide derivatives and MEK inhibitors in sporadic AVMs that are incurable with embolization or other interventional procedures. Here you see some nice examples of AVM response to thalidomide from a large case series from Dr. Vikula, who's a geneticist, and his colleagues in Belgium on the left, and then 2 case reports of trametinib for isolated AVMs on the right. When and how best to use these agents is still unknown, but these are examples of situations where previously patients had no options and now there's hope for their future. So we've made a lot of progress in terms of medical therapies for vascular anomalies, but there are still so many things to work on. And despite the promise with thalidomide and MEK inhibitors, many AVMs remain incurable, and novel approaches are needed. A large proportion of patients with venous malformations, in particular the more complex and extensive lesions, they harbor a Tie2 TEC variant, and so they may benefit from specific Tie2 inhibitors. Topical sirolimus, like we talked about, is already available, but we don't have any topical trametinib. There are also examples of drugs that show promise, like morancertib, AKT inhibitor in Proteus syndrome, but there lacks funding for these medications. And so there's also much we still don't know about each of these drugs: long-term safety, good PK data, and how can we minimize toxicity? And the biggest question we have from patients is, when do we start? Infancy, early childhood, puberty, or when they have an issue and then start the medicine? How can we have the most impact while not compromising normal growth and development? Another big question: how long do we treat? Forever? A few years? Or maybe something else? And so to address some of these issues, we've come together as a national group of vascular anomalies through the Consortium of Investigators of Vascular Anomalies, or called CANVAS. Dell Children's just recently became a member. We currently have 24 participating sites, and the leadership board is comprised of 4 major national leaders in the field, led by Dr. Denise Adams, who's now at CHOP, and Dr. Michael Jang, who's at Stanford. We also have 2 patient advocacy groups that are included in this: the Lymphangiomatosis and Gorham Disease Alliance, LGDA, and the Klippel-Trenaunay Support Group. More importantly, this is a multidisciplinary group of co-PIs at many centers from fields other than hematology oncology. So co-PIs can be surgeons or ENT or IR people. Through Canvas, we are all trying to collaborate together to improve our understanding of natural history, supportive measures, and disease outcomes. The use of novel therapies in this patient population are absolutely important. We have multiple studies going on, and we have planned studies, including a prospective study evaluating the effect of anticoagulation on pain and quality of life in slow-flow vascular malformations. That study is actually closed. I lead that through Arkansas Children's, and we have 6 or 7 other institutions participating in it through Canvas. And so in this study, we looked at patients with venous malformations or slow-flow vascular malformations who had decreased quality of life, pain, phlebolysis, issues with clotting, and that we're going to start on anticoagulation, whether it was low molecular weight heparin or a DOAC. And we looked at their labs, their pain score, their quality of life at baseline, 2 weeks, and 4 weeks. And we enrolled over 50 patients, and what we have found, it's in the manuscript writing process now, what we have found that anticoagulation will statistically decrease their D-dimer, their pain score, and improve their quality of life. So a lot of us are utilizing anticoagulation for pain. We may need somebody truly from a pain standpoint to help with other neuropathic pains in the future at our institution. And so we also have a lullaby study, which evaluates disease response rates, again, quality of life, pain, functionality in patients with complex lymphatic anomalies, receiving a standard of care dual pharmacotherapy regimen with sirolimus and zoledronic acid. Both of these studies have exploratory biology sub-aims. And finally, we have a VATCH trial. It's kind of like the MATCH trial. It's Vascular Anomalies Therapeutic Choice, which is a master platform through which we can enroll patients on drug trials based on their genotype-phenotype matching. We currently have 2 protocols set to open very, very soon. One of them is on alpelisib. I'm the co-PI on the alpelisib trial, and then we also have another one for trametinib. We plan to add more agents through the same platform as they become available in the future. As we look forward to the future, we know that the genomic knowledge gained in the last decade will provide many more medical treatment options to our patients suffering from vascular anomalies and their associated complications. and as hematologists and oncologists are uniquely poised to help care for these children and adults and manage the drugs that can control these diseases. It's just amazing how much this, I've shown this slide 3 times now throughout my presentation, and it's just so amazing how we've gotten to this point over the past decade. I'd like to thank Dr. Denise Adams, Adrian Hamill, and Dr. Alexandra Bors for letting me borrow some of their patient pictures and then some of their slides as well. This is our comprehensive vascular anomalies group. Dr. Richter is standing behind me. He's our surgical director. I serve as our medical director. We have an interventional radiologist who's part of our core group. We have a geneticist who's part of our core group, and psychology is part of our core group. We have surgery and gynecology who will pop in and out when we need them for certain patients. And then we have this huge ancillary staff, which we couldn't do anything without all of them. We are always open to patient collaboration, research, education initiatives, and we're a pretty close-knit family anyways from a vascular anomaly standpoint. Everybody knows everybody. But thank you guys so much for listening.
No, that was great. Thank you. And we'll open up for any questions.
Great talk, Joanna. Thank you so much for being here. I'm curious now, they were not on your slides, but sort of the pan-RAF inhibitors, drugs like tovorafenib, which are showing great evidence in pediatric brain tumors, which is where some of the other drugs got their start. I'm just curious, you would know better than I would, have there been even any case reports or any, I would suspect maybe there would be more hope for those drugs that have sort of that more broad effect on those affected genes.
I haven't heard any of our group using it yet, or at least have a case report in hand, but there may be some people who are using it. And I think that's the big, it's a problem, but it's also a gift. When one patient responds well to one medication, everybody, the patient family groups are so intertwined with each other, and they're quick to jump on it, like thalidomide, for example. Everybody wants thalidomide. And it took me 2 years to get the cobimetinib trial approved and to start enrolling, but nobody wants that drug anymore. They want thalidomide. So it's moving so rapidly, and so I wouldn't be surprised, but I haven't heard anybody yet use that.
Yeah, it's a blessing and a curse.
Yeah, exactly.
And I kind of missed it. When you talked about thalidomide, you were talking about arteriovenous malformations, right? Did you say there's a trial? I missed that.
There are no trials right now. That was a retrospective study.
Okay.
But, and again, it goes back to, I wish that when we would start to hear that thalidomide is working on an AVM or somebody's looking through or using it already, I wish we would all get on the same page where, hey, these are the time points that we're going to get labs, the time points that we're going to get imaging, so that way we can at least start that process.
Because anecdotally, it's been 20 plus years ago, I had a young patient with a P10 mutation and a huge arteriovenous malformation of her leg. And I talked to Roberta Clement in Boston. I don't even know if she's practicing. She recommended Celebrex and thalidomide. I treated her for 2.5 years, and it was dramatic improvement.
Really?
Yeah.
Oh, wow, that's amazing. So it's come all the way back around. We're more popular. These patients are so unique. So even if they have PIK3CA mutation and they're diagnosed with KTS, the lesions are in different places. The lesions are smaller in one person and bigger in another person. And so not one patient can ever be treated exactly the same. They all have, and I think that is another issue when it comes to research in this realm, is that we can't just say, you have leukemia, we know what what our endpoint is, your MRD needs to be 0. These patients with vascular malformations, is our goal to have no evidence of disease in the arm or no evidence of disease in the leg, or is our treatment to improve your coagulopathy? It's hard. It's what the patient wants. Like I had a patient, I wish I would have shown you this picture, who had cloves with a PIK3CA mutation, who was doing well. He maybe a little malnourished, but was at school playing soccer, had no coagulopathy. For the most part, you'd say is super healthy, except he has clove syndrome. The one thing that bothered him was that his leg discrepancy. His right leg was probably about 6 inches longer than the left leg. Nothing that a shoe lift couldn't fix, but that's what him and his mom wanted. So he ended up having an amputation of that leg. But it goes back to, it is very individualized care, and our goals need to be set at the beginning of what we want, how do we want to treat these patients.
And then I actually had a question kind of about just sort of sirolimus duration. So for a patient who's on sirolimus and maybe they're on it for a year, have a really good response, they come off, what's been reported, what's the sense of like rates of recurrence or reworsening? And then in those cases, does adding back sirolimus work, or usually then you have to kind of jump to other things?
So I don't think we've looked at that yet about, I'm sure that study from 2016, they're following those patients. And we'll probably have some good reports from those patients of how they've done after being off of sirolimus. I will tell you, I've had some patients that we've had to do a slow taper off of it to the point where they were on sirolimus every 3 days, for another year, and then coming off of it. But I don't know that answer yet. I don't think we do.
Sure. Okay. All right. Any other questions? Check the virtual.
Not everything is a hemangioma. Okay. Thank
Awesome.
you.
Well, thank you so much.